Good morning, ladies and gentlemen. Welcome to MSI webinar series, the first edition in 2025. Today, our discussion topic is born out of the recent events following the assumption of office of the President of the United States of America, Donald Trump. Following his swearing-in, we observed massive foreign policy changes that is impacting on health funding and program implementation across the world. And in fact, global health service delivery and every other aspect of it is a major discussion on the lips of everyone across the world. Today, we will be looking at understanding the impact of these events. It will be great to highlight that within 3 months of the assumption of office, massive changes have occurred. In January, following the assumption of office, we heard that the President, Donald Trump, had signed the Executive Order 14169, titled Re-evaluating and Realigning United States Foreign Aid. He initiated a 90-day pause on all U.S. foreign development assistance programs for review. 1 week later, the United States Department also suspended all existing foreign aid programs with exemptions for emergency food assistance and military aid to Egypt and Israel. 4 days later, precisely on January 28, 2025, exemptions were made or expanded to include humanitarian programs, providing life-saving medicines, medical services, food, shelter, and subsistence assistance. 1 month later, a directive was issued placing all USAID direct hire personnel on administrative leave globally, retaining only those responsible for mission, critical functions, core leadership, and especially designated programs. And in March, the Secretary of State, Marco Rubio, announced the cancellation of approximately 5,200 out of 6,200 USAID programs following a 6-week review, with the remaining programs to be transferred to the Department of State. These happenings informed the topic of discussion today, which we have entitled Understanding the impact of the USAID funding cuts on SRH gains in Nigeria. To make sense of this topic, we have with us notable thought leaders, government at different levels, head of organizations, and implementing partners, and other interest groups that are concerned about sexual and reproductive health in Nigeria. Together, we would be discussing this topic, and we expect that this opportunity would be useful to explore all the aspects of health system that is affected by the funding cuts. We would be discussing the impact of the cuts on the SRHR sector, especially as regards access to services and supplies, as well as financing. We will be identifying the strategies and approaches to fill these gaps to forestall grave consequences. And finally, we would be identifying steps and actions that we would all be taking to respond to these changes. Today, I'll be your host for this conversation, and my name is Anne Taiwo. I work with MSI Nigeria Reproductive Choices as a strategic research and learning, as well as program design and development manager. To kick off this conversation, I will introduce my guest speakers. I have, in absentia, I believe she will join us soon, Dr. Bierem Okari, Director of Family Health, Federal Ministry of Health and Social Welfare. I will be joined by Camilla Higgins. She is the Director, Nigeria International NGOs Forum in Nigeria, which is an alliance of international NGOs providing humanitarian and development assistance in Nigeria. I have with me here Dr. Bartholomew Boniface, the Chief Executive Officer, Heartland Alliance Nigeria. Heartland Alliance Nigeria is an organization that is focused on HIV interventions, bringing treatment, psychosocial support, tuberculosis care, cervical cancer screening, health justice, and supporting survivors. My other guests include Dr. Farouk Umar Abubakar, who is the Honorable Commissioner for Health, Sokoto State. I also have Dr. Sani Dambam, the Honorable Commissioner for Health, Bauchi State, who is ably represented by Nuru Yakubu Umar, Director of Planning, Research and Statistics. And lastly, I have the Country Director, MSI Nigeria Reproductive Choices, Mr. Emmanuel Aja. At this point, I'd like to pause to give the Country Director of MSI Nigeria Reproductive Choices the opportunity to give a welcome remark before we continue the conversation. You're welcome, sir.
Thank you very much, Dr. Han, and good morning, everyone. I'm so pleased to have us here, joined together to have this critical conversation on the pending and emerging issues as far as the court that has happened with the USAID and by extension the larger US government support is across the countries, especially in Asia and Africa, where the AIDS have been supported. I'm so pleased to have all the panelists or speakers join us in MSI today, because we do understand from where we sit that this is not just about MSI alone. And we have other partners from both other organizations as well as the governments at different levels who have direct or indirect impact of this court. I'm so pleased to see that you have joined us to have this conversation. Camilla, you're welcome. Miriam, I'm so pleased to have you. I know you will still join. The Bauchi State Commissioner, who is now represented by Dr. Nuru, you are equally very much welcome. My brother and friend, from Heartland Alliance. You are very much welcomed. And of course, my very good friend and boss from the Sokoto Ministry of Health, the Commissioner, you are also very much welcome. So today, largely, we'll be asking ourselves, what is the wider impact and implication of the USAID funding cuts on development activities in Nigeria, especially on sexual and reproductive health gains? It does appear from all indication that we are making a lot of impact and we're actually making a lot of progress. For those who joined us during the 2024 Family Planning Conference, it was very clear and very glaring that we're all making a lot of impacts in terms of progress towards achieving the FGPR goal that we all want to see. We had seen a lot of improvement from different states, even as we saw some drops in one or two states that we needed to have asked ourselves what do we need to do to ensure that they maintain the momentum that we're already seeing. But having this cut at this time is as bad as one would ever expect. And it's actually a very beautiful and lovely time for us to start having the conversation. What is the implication of this? And then equally begin to ask ourselves, how do we mitigate this impact? What do we need to do as partners, as governments, and as well as organizations who are implementing SRS products? What do we need to do? What does the future hold, and what specific steps do we require to ensure that we get ourselves still remaining on track? Because at the end, there are women and girls who are out there who need our support, who will continuously need the services that we provide. So I welcome all of us this morning to please pay attention. Drop in your messages or your questions or comments on the chat box, or write them out. When we do have the conclusions from the various speakers, we'll be able to get some of your feedbacks and respond to it. But overall, too, is that we all need to collectively begin to ask ourselves, as individuals, as groups, as government, what we need to do, because the reality is on ground that this cut is happening. So it's going to impact on the demand generation activity that we have as far as SRS is concerned. It will continue to impact on what happens with training of providers. It will likely impact on what happens with providing commodities that are needed to make sure that we provide services when they are required. So what do we need to do collectively and individually? What do we need to do as organizations, and what do we need to do as government? So let's pay attention and then hear from the experts and then the different persons who have direct or indirect impact on this, and be able to ask questions and make our own contributions, because collaboratively we are sure we'll be able to navigate through this. Thank you once again. You are most welcome to this webinar. And over to you.
Thank you very much, Mr. Emmanuel Aja, Country Director, MSI Nigeria Reproductive Choices. I'd like to recognize those participants online. Thank you for joining. Please do well to introduce yourself and the organization you represent. And feel free when it's time to make your own input, feel free to do so, and we'll really appreciate it. Thank you for joining once again. I also want to enjoin all of us to reach out to our friends who may be interested in this topic to join the conversation, so that together we can forge the way forward. That said, I'd like to kick off this discussion with my panelists, those that are on ground, and for those that will join us, we'll let them know the questions that whenever they meet us, we'll let them know. So I'd like to start with my guest, Dr. Bartholomew Boniface. Sir, you have been in the SRE space as long as I can remember, for many decades now. And I see that the organization has moved from stride to stride, making impact. Would like you to, discuss this topic with us this morning. Let's start with, when you heard about the news of these changes in the foreign policy and the USAID funding cuts. Did it come to you as a surprise? And how did you take it?
Yeah, thank you very much for that question, Anne. And this is a very important topic, very contemporary, very timely. The cut in funding with the executive order that resulted to the stop work for USAID funded activities globally actually came to many as a big surprise. Big surprise in the sense that it was too sudden, and just less than just few weeks or few days into the new administration, when people are still trying to figure out what is going to happen, what will be the policy direction, and it was very big and massive, not just the fact that, it's a stop work order, it is blanket, it covered so many things from health to education, to nutrition, to climate change, even, funding for world bodies like the WHO and the rest. So it's big. And like your country director said earlier on, even the low and middle income countries were worse hit or are worse hit because of this, because again, our dependence on the US government was overwhelming. In Nigeria, for example, the HIV response, depends on the US government over 90%, from commodities to a human resource for health, to drugs and all of that. So I must say it came as a big surprise. I knew something was going to happen personally, but I didn't know it would be this drastic, it would be this massive, it would be this all-encompassing, and it was a difficult one. Thank you.
Thank you very much, Dr. Boniface, for that. I'd like to follow on to ask, I think you're the only speaker on ground at this time, so we'll just continue the conversation. When they join us, then we can get their own views. Thank you. So like you rightly said, it came to us as a surprise, and we also know that such foreign policy changes, especially as regards health financing, could have far-reaching implications. So from your view, how has this incident impacted on your organization and the work that you do? Maybe if you can highlight a bit about what you do and then how the funding cut has impacted your organization, looking at the different aspects of the health system. I think that would be great.
Okay, thank you very much. And so Heartland Alliance works basically at the intersection of health and human rights. And we do a lot of work with populations at high risk to ensure they have access to life-saving interventions, such as the prevention and treatment of HIV. We also implement the comprehensive treatment program, which increase access for pregnant women to, prevention of mother-to-child transmission, pediatrics and adult treatment of HIV, as well as, broadly speaking, working with the key populations who are at higher risk of, contracting HIV. We do a lot around mental health, for different populations, and we do a lot of work also around gender-based violence, where we have, group of service providers, from health to legal to social, as well as, mental health programs addressing, gender-based violence. So those are some of the things we do, and this, disruption really affected all of those components of the work we do. Initially, it was a blanket stop work, and that lasted for, I think, between 24th of January till about 6th of February. So that was between two to 3 weeks, of people really not knowing what to do. Most of our offices were shut down, people could not go to work except for the country office, which we own. And so that, wasn't really a funded space. So to that extent, we were able to have at least an operational base where we could sit down and think. We were meeting every day, so it brought a lot of burden to the leadership of the organization, from the board, to the senior management, as well as other management system across the organization. But in terms of direct impact to the program participants or beneficiaries, as it were, there was reduction, because as from, I think, 6th of February, there was like a partial resumption of work for some programs. So the disruption of services really was a big shock, even to the people living with HIV, and other programs that access our prevention programs and all of that. So it was a big shock, because you can't even come to the service delivery points to access services, because you wouldn't meet anyone there. And then for some of those services provided at government facilities, you come there and sometimes you won't meet individuals that will provide services for you, because the human resource for health was also supported by this program to a very large extent. So that reduction of services, that disruption of access to programs, not just HIV, malaria, tuberculosis, and all of that, really was massive. Then in terms of staff, we had to lay off staff, because it was difficult to sustain all of the staff that we have. And if you do an average in Nigeria, for example, an average worker has between 4 to 5 dependents, people who depend on you directly or indirectly. And so if you do the math, you can imagine the number of people that were affected, because we had over, up to 500 full-time staff, over 1,000 volunteers, and across the cascade, people were really affected. Then for the organization, there are legal and operational challenges too, because you have, landlords you are paying rents to have an operational space in the other states. You have agreements with vendors, with suppliers. So, you can go on and on. The effect is unbelievable. It's like a tsunami of some sort. So the confusion, we have not recovered, if I must say, but it's just massive and unbelievable.
Thank you very much, Dr. Boniface. While you were speaking, I had the Commissioner for Health, Sokoto State, join us. I also have the Commissioner for Bauchi State, the representative of the Commissioner also join us, and I want to make them welcome, to recognize them, and then we can proceed from there. Thank you very much, sir and madam, for joining this conversation this morning. We appreciate you for making our time to be part of this conversation. Thank you, Camila. We already started. We know you had some other activities that you had to complete before joining. Thank you so much for making the time to be part of this conversation. We already had started before you joined, and though we haven't gone that far, we're exploring the impact of this event that has happened, that is on the lips of everyone. The funding court, the USAID funding court, did it come to you as a surprise? And if it did, how are you responding to this? How are the partners that are members of the INGO forum responding to this disruption. Over to you, Camila.
Thank you so much. And indeed, my apologies, everyone, for having joined you late this morning. I had another event, which was also running late, so I managed to leave it early. And thanks very much for convening this discussion. Yes, we understand that this has been a huge change in circumstances and funding environment, and has impacted a very large number of partners here across Nigeria. I'm not sure if anyone has already shared this statistic, but prior to this year, US funding represented 59% of the funds for the humanitarian response here in Nigeria, so not a small number. So the effects of this are very far-reaching across members of the INGO Forum. We have 61 members operating across Nigeria. It's not to say that everybody's been impacted, but a very large proportion of our membership has. For the forum itself, we've also been affected. We were reliant on US foreign assistance through BHA for about 50% of our funding. So it did certainly come as a shock to us, although I believe many will say that it shouldn't have, that we should have read the Project 2025 manifesto of Donald Trump and seen this coming. However, I think the speed of change is something that nobody could have foreseen. And the strategic nature, or strategic and chaotic at the same time. In terms of impacts that we're seeing, I mean, we're aware that the most worrisome consequences were on healthcare services. You know, we're aware that a number of INGOs are literally running clinics in various parts of the country, reliant on US funding, and that these healthcare services, including sexual and reproductive health services, had to be paused overnight. I would say what we've been really dealing with over the last several weeks is just a huge sense of uncertainty, as well as to which activities can continue, which cannot. And so even where, we've seen various communications coming from the US authorities about what is stop work orders and terminations, and then projects being allowed to restart. But the problem is that even where projects are being allowed to restart under this description of life-saving, it's unclear what the exact definition of life-saving is. And additionally, the major issue we've seen is the lack of cash flow, as the payment system that is usually operated by the US has been down for, or was certainly down for a period of several weeks. So even if organizations were secure that their projects could continue, they couldn't actually access the funding to be able to deliver activities, which is obviously of significant concern. It's not just like healthcare services that have been affected, though. Services across the board, particularly those that could be seen as less easily defined as life-saving. So education, livelihood support, protection services, we've seen a lot of those things stop, as well as water and sanitation and hygiene. There's also a lot of uncertainty around those activities in the early days. We're aware that a lot of our organizations have had to halt their projects and scale down their interventions. I'm constantly hearing of INGOs having to close offices, obviously lose a lot of staff as well, which is a major concern, because a huge capacity has been built in national staff who have developed their careers over the past 15 years working in this sector, and suddenly there isn't enough funding to sustain the work that they are skilled to do, which is still needed. So it has definitely been a shock to the INGO community, but we are certainly working with core stakeholders, including other donors, but also importantly the government of Nigeria, to try and explore what alternative mechanisms there are for continuing funding to these important projects and activities, and try and mitigate some of the risks of a very sudden closure of important aid work. I'm sure there's a lot more to say, but I'll maybe pause there for the moment, because I'm sure you want the conversation to evolve a little bit.
Thank you very much. Well said. I totally understand, what this means, especially given that some of the services are really not defined as life savings, and it could really have far-reaching implications, because some of these services are quite complementary, even if they are not in the same sector. We'll come back to you to explore further around the response of other donors. We can as well discuss that now before I move to the government to understand their own experience. Can you speak a little bit about how other donors, apart from USAID this time, that are responding to the incident?
Certainly. So it isn't just a withdrawal of US funding, right? That has been a catalyst and a sort of has been a preliminary step, but really what we're seeing is this as a pattern of changing government priorities across the globe, and most particularly across the Western world, let's be frank, and most particularly across Europe as well. Part of the reasons for this are the growing right-wing sentiment across Europe, and also the growing fears of the implications of the Russia-Ukraine war. And so we are seeing a lot of European governments in particular needing to redirect their funding priorities towards defense priorities rather than international assistance. And that's in response to the politics, the geopolitics that they're facing within their own country. So in addition to the US withdrawal of funding, we're aware that the UK has already announced a cut in aid spending. Instead of increasing from 0.5% of GDP up to 0.7%, they've gone in the other direction, down to 0.3%. And the argument for this is that at this moment in time, in order to finance sufficient defense spending, international assistance isn't sufficiently justified, which is obviously a very sad message. And this is being echoed across Europe. So we're aware that the French have made similar indications. We're aware that a right-wing government has been elected in Germany, and so we can anticipate much of the same. And this will inevitably impact the European Union as well. Although ECHO, the Directorate for Humanitarian Assistance from the EU, has maintained its budgets for this year and has done its best to try and keep as many partners as possible going for as long as possible. So they have spread themselves more thinly across a wider range of partners rather than fund fewer projects with larger grants. I'm not sure how long we can expect that to continue. Really, I think we are entering a new world when it comes to foreign assistance. I can't say how long it's going to last, but certainly the period that we're entering right now is one of more overt self-interest of individual states, which obviously includes donor states, and less political will for international assistance and cooperation and the means of soft diplomacy. So I really do think we're going to be going into a sort of what's the word I'm looking for? Ice age almost for the world of humanitarian and development assistance. I think things are going to become a lot smaller scale going forwards.
Thank you very much, Karina. Thank you. I'd like to give opportunity to Mr. Emmanuel Aja to speak from his perspective. I know that not all organizations received the USAID funding, and we may not be able to say whether or not they are impacted. We're all in the same ecosystem, and the impact might vary. In that regard, I'd like to invite Mr. Emmanuel Aja to speak from his perspective and experience regarding the USAID funding cut. Over to you, sir.
Thanks again, Dr. Ann, for calling me to this very useful conversation. So if we are looking at MSI in Nigeria as a whole, we are probably not directly impacted by these cuts, but we are obviously indirectly impacted by the cuts in multiple ways that I will explain. We did have some situations similar to this sometime in 2017 when we had the biggest grant that was being supported by the USAID. And that's the grant that we used in growing what you presently have as the big chunk of what is happening with the public sector support across 20 states. And when this same government took over, when I say this same government, I'm referring to Trump in 2017, we had a similar situation that meant that we were not able to receive funding because as an organization, we do not sign a gag rule for any reason. We understand our mission, we understand our vision, and we are very much focused on those mission and vision of ensuring that no woman dies as a result of anything that has to do with pregnancy. So with family planning and all that, we are so much focused on our mission of ensuring that we provide reproductive health covers for women and girls across the country. And as such, when we couldn't sign the gag rule, and that meant that we lost all the grants that we had that stemmed from the FH Plus as well as the CIFO grants. So fast forward to 2025 when this happened, we had built some other funding portfolio and some other pipelines, which has been supporting what we do here. And we can say that for now, pending what happens throughout the whole of this year and possibly till next year, we still have some funding that can keep the staff that we have now. So overall, we are not. However, we do have larger impacts, like Camilla tried to explain. This is huge in terms of what comes in here. So what that means is that what is happening with UNFPA and commodity logistics will indirectly have some impact on us. So if UNFPA is not funded, or the funding is reduced, or even the funding for commodity distributions and the rest of them are not available, that's going to have large impact on what we do. But more importantly for us too, because we do understand that as an organization that is aimed towards ensuring that we have children by choice, not chance, and having a world in which every birth is wanted, that we are not going to be able to just be the only organization that will be achieving a world in which every birth is wanted. So there are other organizations that have been contributing towards this vision of ensuring a world in which every birth is wanted. So what is happening is that when you go to these states now, if I go to Bauchi, for example, the grant that was being implemented there is off. So because what was happening is that MSI is contributing our own quota based on the funding that we have, and then based on the fund that was available to other organizations, as far as you said funding was concerned, they were equally contributing. And we're all collaborating to make sure, is it demand generation, is it commodity security and logistics, or is it training of providers, or even the coordination that we want to see. We're all collaborating to do that together. So by the time we begin to see that our colleagues are no longer there, regardless of what we think we have, is going to continuously pull us back. And we are one of those organizations that has been pushing to see how do we move the MCPR to where it should be going. And we were so excited when we saw the last NDHS report that came through from when it was presented, partly during the swap meeting, and then when it now came very clearly during the FP conference conversation that we had late December or early December last year. So it gave us some hope that we're all moving towards some direction. But just looking at this is showing that a lot of those hopes are now becoming a bit bleak, because probably the little that we'll be able to throw in there is not going to sustain that tempo with which we're seeing that was going to take us to where we wanted to move to. So I think overall, that's the terrible picture that we are seeing, Dr. Ann, and which was why in my opening speech, I'm saying now that we have other partners and other stakeholders, especially with government, what do we need to do as a people, as a government, and then collaboratively as one people that are affected directly or indirectly by this, in ensuring that we sustain the tempo and continue to move the needles forward. Thank you.
Thank you very much, sir. Well said. Collaboration in the ecosystem definitely will be impacted. Commodity security is a major factor that has to be managed, and that impact on service delivery, which Camilla had alluded to, At this point, I want to invite the Sokoto State Honorable Commissioner for Health to lend his voice, to let us know how the state received this news and how they are responding. I mean, what the impact has been, given that all that partners do in Nigeria, as far as intervention is concerned, we are doing this in collaboration with the government. But we want to hear from the government to understand what this had been like for them. Over to you, Honorable Commissioner for Health for Sokoto State, Dr. Farouk Umar Abubakar. Doctor, sir, you have the floor. While we wait for him, I have here with me, okay, Dr. Farouk, please, you can unmute yourself and speak. You can unmute yourself.
Yeah, I'm trying to unmute.
We can't hear you, sir.
Are you hearing me?
Yes, I can hear you now. Welcome.
All right. Good afternoon.
Yes, sir. Good morning,
Good
sir.
afternoon. Yeah, good afternoon, every one of you. Let me apologize for joining late because of attending other study engagement, but I have to quickly rush and conclude on and join these very important discussions. Thank you for that. We are understanding. As you rightly mentioned, the kind of support we receive through the USAID programs, they are enormous, and which include procurement, family, and reproductive health commodity to the states that is widely distributed and utilized by to all the primary health centers and the facilities. And we also receive the warehousing of commodities in our state through the USAID programs. We also, the same USAID program support for the distribution of about all the commodities to 587 facilities across the 23 local government in the state, as well as the capacity building to service providers on logistic management. They are all part of the benefit what we have been receiving through this USAID programs. So far, the Trump policy of withdrawal support from the USA, certainly we observe there are certain impact on the health sector due to recent funding that may affect the entire service of Sokoto State. Currently, as a result of suspensions of the USAID support, our health facilities were stocked out of family planning commodities since when this policy came in force. However, the government of Sokoto is responding through requesting all our implementing ministries and agencies to track all the activities supported by USAID for funding from the state government so that we'll be able to continue without creating gap. And the other parts, developing partners are also taking the responsibility and support, like UNFPA. They are also doing a lot because the USAID is the one that's responsible for the distribution and they ensure that such commodities are well delivered. I think we also receive a signal that UNFPA is going to close that gap and provide the support to us. On the part of the lesson that we learned by the government regarding the recent reduction in the funding for development partners, the lesson we learned include the state government should be able to develop our own strategy that will reduce over-reliance on the partner support. I think we have taken note of that, and I want to assure you we are going to deploy a number of budgetary provisions on those areas so that we cannot be over-reliant on those policies. At the same time, we need to develop our own sustainability plans in order to have the ownership of all the areas being supported by the USAID and other partners, so that we avoid such kind of situation that will happen instantly. The other aspect, you also mentioned that aspects of sexual and reproductive health in our states that require attention, both in short-term and long-term, include the distribution of commodities that were received at the state warehouses. Before the suspension, we usually receive support to distribute these commodities to all the 589 health facilities across the state. And unfortunately, such support is not there, and we need to look for other partners to continue on that basis. We also need to develop a plan for continuous supply and distribution of those commodities where they were stocked and they were suspended. I think we also have to do that, so that we need to continue supplying, we need to continue providing those services to our respective community across the state. As well as the government takes some measures, some action the government may take in order to achieve health program will include, we need to scale up all the USAID supported activity in the state, so that we'll be able to avoid and close the gap. Another approach that we need to do is to engage other relevant stakeholders, so they'll be able to provide support in the same areas the USAID program is being handled, and as well as the continuous capacity building on various stakeholders to ensure sustainability and the ownership approach of all the health-related program in the state. Let me also highlight some of the other areas being supported by USAID, and they are also affected by these recent fundings, include maternal, newborn, and child health. Usually receive a lot of support, especially when the USAID provides establishment of drug revolving fund scheme, where it needs to be revolved and continues on the basis of supplying drugs to our primary health centers and health posts and health clinics across the state. We also receive support for the training, improving the human resource for health through the USAID health management activities. It's also another area where the state is also receiving support and improving the capacity of training of health workers, the core health workers, nurses, midwives, community health, CHIWs, and what have been. And I think the USAID program is also doing a lot on that. But today, with the cutoff done, such kind of support is no longer there. Another area where we also support leadership and governance through the USAID, state to state, is also another area where the state is also benefiting. It is this state to state is strengthening the system, is strengthening the activity of the Ministry of Health, and now such support has been withdrawn. Then we also look at another avenue or through other partners where we need to continue on that basis. I think these are some of my just input that I need to raise as far as this discussion is concerned, related to USAID sudden withdrawal of support to various programs being implemented in the state. So it is my hope and desire that other development partners should take up the gap and now continue providing these humanitarian services. Thank you very much. That's my own input.
Thank you very much, sir. Well said. We hear you. The disruption of commodity distribution was top on your list, and the impact on HRH, that's human resource for health, and the training of health workers, especially the core health workers. I also hear you regarding the sustainability plan that Sokoto State is about to develop to see how you can bridge this gap that has been created due to the cessation of USAID funding. I'll come back to you, sir, so that we can unpack this sustainability plan and then we can understand more what the plans are and how you want to go about it. I'd want to also pause and give opportunity to Bauchi State Director, Planning, Research and Statistics, who is representing the Honorable Commissioner for Health, Bauchi State. Over to you, sir. Hello, Dr. Nuhu. Are you online? While we are waiting for Dr. Nuhu to join us, I understand, Camilla, you have a question. I'm told you have a question. Do you want to ask now?
Thank you. Yeah, not so much a question. I just wanted to, if there's the opportunity, I wanted to respond to a couple of the things that have come up from other speakers, but only please prioritize hearing from all the stakeholders first.
I think you can use this time to do so while we wait for Bauchi State Honorable Commissioner's representative to join.
Thank you. So I just want to jump on the point that's been mentioned by a couple of others so far that we're, and I alluded to very briefly at the end of my opening remark that we really do need to capitalize on this as an opportunity. Whilst this is devastating in the short term, whilst because of the shock and the suddenness of the change in funding prognosis, I think we really do need to think differently about how we do the work that we do in countries, especially countries like Nigeria. And I think this is what has been spoken about quite ably by our colleagues already on this call. But I would caution slightly against placing too much faith and hope in development partners as being able to solve the problem. Because we have to be aware it's not just humanitarian funding that's been cut, it is aid assistance in general. And I think we're going to see drastically smaller budgets for quite a significant period of time. So I would really welcome opportunities to interact more with the authorities to identify how we can support them to strengthen internal and national systems to ensure that services can continue to be delivered for populations in need to the greatest degree possible. But we need to spend some time thinking as a community about how to do that, and we need support from our donors. Number one, to have the time to have those conversations, and also to have the funding for the necessary capacity strengthening or other initiatives that are needed to make that a reality. So I think what we are ultimately calling for as a forum is more of thinking of this as a transition. It's a time of transition for aid work in Nigeria, but that means we need to really put our collective efforts towards transition rather than just shrinking back to do the minimum amount that we can with the small resources we have. That's one concern that we have, is if we simply focus on the priorities of the priorities of the priorities, we're not thinking differently. We're thinking along the same lines of doing the same as we plan to do, but with less money. Our argument is we need to think differently. We need to do differently. We need to get outside of the box and really think about the long-term future of Nigeria and Nigerians, and how we can best facilitate that in the long run.
Thank you very much, Camilla. I totally agree. I'm sure that other participants also agree that we actually need to explore the opportunities and begin to explore how we can think differently, holding those conversations, coming up with ways we can mitigate the situation, especially not just for the short term or immediate term, but for the middle and long term healthcare financing in Nigeria. At this point, I'd like to open up the conversation to the online participants. Before we begin to look at the strategies we could adopt to mitigate the situation, we want to give room to the online participants to also make contribution on the impact of the USAID funding cuts. So if you want to speak, you can raise your hand and then you'll be recognized and given the opportunity to speak. Over to our online participants now. Perhaps we can start with questions on this segment before we take on any hand that might be raised. So if you want to speak, you can raise your hand. I'm trying to navigate to the questions, if any.
Ejiro has raised his hand. Maybe you should just recognize him to go ahead, please.
Ejiro, do you want to speak, or was that Miro? He was just trying to check if people are having challenges to raise their hands. So if there is no hand raised from the audience, I think we will want to give the time to the representative of the Honorable Commissioner for Health.
And there are questions on the chat box that can be taken.
Okay, I see one. The question reads, how can state and local governments be better positioned to take ownership and increase domestic financing for SRH programs, especially in underserved and rural communities? This speaks to our next set of our next session, which is on the strategies and ways to mitigate the experience. But there's another question here that's from Edachi Abraham Abutu. Please, if you're not asking a question, you can mute yourself. Ask a question. Okay, I'll take this question. Considering the USA and potential other foreign aid cuts on SRH and other health interventions in Nigeria, what strategies are being explored to leverage existing community structures, such as traditional leaders? And this question is also speaking to the strategies to respond to the problem. So I'd like us to go straight to that, and I want to invite Dr. Boniface to walk us through your thoughts on what strategies that could be adopted to mitigate the impact of the USAID funding cut.
Okay, thank you very much, Dr. Ann, for that question. You know, earlier on when Dr. Aja was speaking, he said, and I think I also agreed with him that it was the right time to speak about this. But on a second thought, I thought that we could have started talking about this 5 years ago, right? And, you know, seeing the handwriting on the wall, trying to work with different government ministries, departments, and agencies to proactively prepare for this was scenario that we are experiencing right now. But be that as it may, it calls for prudence in terms of resource management, because if you look at the total money contributed and you compare it with some of the resources that Nigeria, for example, has, you agree with me that if we review our priorities and probably focus on health generally, sexual reproductive health, mental health, and other aspects of physical health, I believe that we could be able to address some of these. Remember, I think about 2 or 3 weeks ago, the federal government came up with some resources, that they wanted to use to bridge. How that will be used, who will be involved, all of that is still being unpacked, as it were, but that is a right step in the right direction. Though the figures, I can't remember the exact amount now, is really a far cry from what should be committed to even bridging the gap, and then look at the long-term sustainability of those kinds of government interventions. As we speak, over 14,699 excess deaths are already happening across the different states where services are being cut or being disrupted or being stopped completely. What can be done? There should be a lot of advocacy. I was just coming from Lagos, Edo, and Bayelsa, where I met with the PAMSEX commissioners for health, as well as other stakeholders in the health system, including the primary healthcare department. There is a lot of conversation, and I was happy about that. There's a lot of conversation around that, but it needs to move from that conversation. That's why I said we should have started 5 years ago to have that conversation. By now, we should have been seeing some of the outcome, impact of that conversation. Then, in terms of communication, I think it's important for clear, transparent conversation, both for organizations like ours that have been impacted, because staff are losing their job on a daily basis. How are we managing those people? They have mental health issues. What references do they have? How prepared are they? And that level of preparation requires the organization to be intentional. The human resource units of each of our organizations need to actually work with these staff, to help them transit, seamlessly, as it were. Even in terms of trainings, exposing them to such trainings would really go a long way in addressing that. So this will be my few thoughts for now. Thank you very much, and over.
Thank you very much, sir. Would like to get the input from Mr. Emmanuel Aja. Over to you, sir. We're looking at
Thanks again, Anne, and all that are listening to us. I think I want to come from multiple approaches to this, and I'm going to start majorly where I am, which is in the health sector. Particularly impressed with government thinking that already started middle of last year with regards to SWAP. And I do think that if SWAP is properly organized and harnessed, of course, we're already seeing a lot from the coordinators and the intentions of the minister, the coordinating minister and his team. If we're able to take this forward and get a more robust approach that is built on these principles of SWAP, I think probably Nigeria will be heading towards being able to mitigate this. But more importantly for me, it's not just designing that, but designing it in a way that government of Nigeria is funding what we have seen as the health approach that may provide all the necessary health intervention that we have in the country. And I think similar thing can be done in the other sectors, because you said it's not just about health. There are things that they are doing in agri. There are a couple of things that they are doing in humanitarian sector and the rest. So that level of having that coordinated mechanism in country will be really, really very key. I actually think that there is need for a proper mapping of what were currently being funded by USAID, and then understanding what that impact has at both the national down to the various states, and then begin to ask ourselves who will be able to pick up that. And then that takes me to the next layers of who should be picking that. And that should be from the states. So we should be able to see our different layers as far as state governments are concerned, beginning to say, yes, we'll say this, because at the end, the aids that we're talking about are not meant for the people who are in US. They're actually meant for our people who are down here in the country with us, especially the downtrodden, especially the vulnerable ones who are in those communities where we serve. So it has become a core responsibility because as governments, we all have, government has that responsibility of providing for its citizens. Now that we are getting some of these helps from external bodies and they are not coming, what do we do? Camilla just mentioned some things that we should all be a bit careful in terms of how we plan for this, in terms of what we are doing. And then it's just rang through my head because beyond what you said has done, we are beginning to, the FCD, the British government has made a statement in terms of what will probably impact what happens as far as donor funding is concerned. So it provides for us to have that holistic approach, do that mapping, and then get government to do much more than we are doing presently. I'm not saying that government is not doing a lot. There's a lot that is being done. And like I said, what we see with this swap is already a step in the right direction. How do we get much more commitment from government to ensure that's what is happening? For example, if I take FP commodity, for example, I do think that if government can buy malaria drugs and buy drugs for the rest of some other ailments that we have there, why not family planning commodities? Why not do a forecasting of what is required? Because if all of us have an understanding that the best approach towards minimizing or managing maternal mortality is by family planning, why are we leaving it out? So it means that we should be able to make commitment to ensuring that that is addressed. I really think, talking about the next lesson, I think that we'll have other private donors who are in the country here. There are big companies, there are big philanthropies that are here. And like Bartholomew has mentioned, it has called for high-level advocacies for us to begin to engage and say, if XYZ persons in their own countries are bringing money to invest in the country, there are other philanthropists that are here in Nigeria that should come and say that this has become a challenge for all of us. And I think when we're able to either get government or get private institutions to gather all these stakeholders together to have a conversation that will say, yes, we have heard about this, because the way this has started is probably not going to stop. So we need to ask ourselves what happens in the next 2, 3, 4, 5 years in the future, and then get all of these philanthropists together and begin to think about possible ways of ensuring that we'll cater for the needs of our people. We are talking about the Nigerian people and not any other person. Thank you, Anne.
Thank you very much, Emmanuel Aja. Very well taken. We should look at holistic approach to government funding, not just health, but also other aspects like agric education, humanitarian, and then informing, finding the funding gap based on evidence. So we can use that as the advocacy tool that Dr. Boniface had recommended. That said, I'd like to now turn it over to Camilla. Camilla, you had mentioned earlier about the need for us to not only look at the priorities, but to look at the future. And then you also mentioned that other donors are already using the funding cards as a catalyst to their own foreign aid policy review, which is going to impact on overall funding, not just for the now, but for the future. How do we respond to this? What do we need to do? What strategies should INGOs, INGO community do to mitigate this situation? Over to you, Camila.
Thanks very much. Sorry, I was typing a reply in the chat box to someone's question there. What do we do? We need to talk more. I haven't got my camera on either. Sorry, I apologize. We need to start by reassessing what are the new priorities in this new world, where the funding context is so utterly different to what we had anticipated. We need to rethink where are our efforts best placed, and what are the multipliers that we can initiate to ensure that, you know, wherever there is international assistance, it is multiplied by capacities on the ground. So I think it's up to the international, the traditional actors, the international community as a starting point to reconfigure themselves, figure out what is their unique value add as an organization, what do they, and really focus their efforts around that value add and nothing else. Because when there's fewer resources, there simply isn't the space or the funding available for everybody to do a bit of everything. What we really need to see are organizations here that are going to remain in Nigeria, really focusing on what is their core mandate and what do they do better than any other actor. And then for the rest of what they do, they need to figure out who to hand it over to, how to make sure that essential services don't stop overnight, by making sure that they're handing them over to other actors who can participate. Who are these other actors? In some cases, it may be another international organization. In most cases, it can very easily be a local civil society or a local NGO. So part of our responsibility as a community is to strengthen the capacity of national civil society to be able to administer and account for assistance that they receive to ensure that services continue to be delivered. And that's something we're proactively trying to do as the INGO Forum. We've been running the PLR promoting local response capacities project for the last several years. Unfortunately, it was also cut. Funding to that was cut as a result of the loss of US funding. But we are actively exploring other ways to keep that program running so that we continue to support national and local NGOs to access international funding. But the most important other actor in this has to be the government at all levels, at LGA level, at state level, at federal level, and everything else in between. In many cases, I think it has to be recognized that sadly the status quo and the modus operandi of the last decade or so have created a level of aid dependency in Nigeria, and so it's going to be painful for everybody. But we need to change that, and this means that one of the biggest things we need to work on is accountability, because that's one of the main hindrances and one of the main value adds that international organizations can offer is their greater checks and balances and controls that they have by means of having global representation, by means of adhering to global standards and being globally audited, et cetera, et cetera. So I think a lot of work needs to be done in terms of strengthening accountability mechanisms at the local level so that services can continue to be delivered while ensuring that all the money that goes in goes to where it was intended to go. So I think we really need to come together as well with the authorities and with civil society to ensure that whatever actions INGOs and the international community remain responsible for, they are well and truly aligned with the priorities as defined by local communities and local authorities. So I think that's an important piece of work that needs to be done as well. Again, I'm sad that I'm not seeing enough attention to being paid to this at the moment. I think the international community is still in shock. There's been a need to sort of understand what's going on and understand what the real implications are. But I think that period is coming to an end. We now know that there are going to be significantly fewer resources in the longer term. And so the time has come to think differently and to start looking at this from the ground up again. So I really welcome the opportunity to do that.
Thank you very much, Camilla. Thank you. We would like to hear from the government. When Emmanuel Aja spoke, he talked about the current government approach, the swap approach, and when the Honorable Commissioner also spoke, he mentioned the sustainability and ownership as part of the strategy, and it would be great for us to unpack that now as we explore the strategies to address the impact of the funding gap. I'd like to invite the Honorable Commissioner for Health, Sokoto State, to respond to this question.
Hello.
Hello, sir, we can hear you.
All right. I think the what I'm trying to suggest that we need to provide a sustainable plans. This plan that will give us sustainability plans. I'm making a proposal that sustainability plan should be in place to ensure that in the event of this kind of unexpected policy that has just happened to us, where we have been receiving support just from nowhere, the support just been withdrawn. So this is the time for each of the government to come out with a proposal in the budgetary proposal, I think annual budgetary proposal on those particular areas of support, so that these are some of the sustainability plan I'm talking about. Two, we also solicit other development partners that are within the society or within the state to request them and I feel to them to take over those areas where the USAID programs is being funded. And because of this, we have a BACOM now and we have a gap. I think this is what I'm just trying to suggest, because for now, most of the government has already made provision or budgetary provision has been made, and we don't have it in mind because this just came in this year when the budget has already been passed, appropriated. So we just have to start identifying what do we do against 2026. But for now, other partners such as like European, Canadian, and UK to be able to provide the support and continue from where the USAID program has now ceased to provide support to the most of the state that is being funded by those particular activities, especially on the areas of commodities and also the strengthening the human resource for health, which is a key and important. And I want to believe we have a lot of shortfalls, especially on the outreach and community, where this is the area we need more training and more human resource for health. Because if you are talking about the urban cities, we don't have issues, but we need to expand this kind of support to the rural area and outreach communities so that for sustainability of most, especially the maternal and the infant program. And we need the manpower, human resource for co-health professional to continue those kind of services. So I think this is but for now, we need to project the 2026 budget because already 2025 budget appropriation have been passed by most of the state government and we are now at the level of implementation and it has not been captured in this year's budget. So this is I feel, as the development partners who are so much committed, you need to join hand and probably looking around and see other development partners that can extend those kind of services and continue supporting the state and those programs and continue without creating much vacuum. That is my own view about that issue. Thank you.
Very much. Thank you very much, sir. Thank you so much. While you were speaking, it just popped up in my mind based on all that we have discussed so far. We're aware that the impact on human resource for health is huge. We're also aware that people are in the development space are losing their jobs, and the organizations and partners you are referring to, they do not have a funding to continue. And I thought to ask you if the state has any budgetary arrangement that could be used to mitigate this funding gap. What's the Sokoto state thinking about? Do you want to increase the budget for health funding in the state, or what else can you do in that regard?
Well, it depends now because we need to have to elect a lot of advocacy with the state assembly and the Ministry of Budget and economic planning of the state. And that is all to be done this year, again, 2026. But for now, the 2025 budget has already been passed. And budgetary provision is a long process. I believe the process of next 2026 budget will commence sometime in June. That's the time we'll do a lot of advocacy and see how we'll be able to roll and get a little funding because it's not in their own plan and they are such kind of area is been handled by our development partners, and suddenly we have a vacuum now. So I want to say advocacy has to be commenced in earnest and see how we'll be able to solicit for a budgetary provision against the proceeding year. Thank you.
Thank you very much, sir. Over to Bauchi State Honorable Commissioner for Health, represented by Dr. Nunu, who is the Director of Planning, Research and Statistics, to talk to us about Bauchi State's response to the funding gap and what you're doing currently to address it. Over to you, Dr. Nunu.
Hello, good morning, everyone.
Good morning, sir.
Wa alaikum salam.
Hello.
We can hear you, sir. You have the floor.
Okay. Thank you for giving me the opportunity to talk. Sorry for my coming and leaving. I am to represent my honorable commissioner who is on the transit. Hello.
Yes, we can hear you loud and clear.
Okay. But I can give our gender desk officer will continue on my behalf because I have some short engagement. She will continue. Sorry for this interruption, please.
Thank you very much. If the person is online,
she's online.
Please let her introduce herself and then respond to the question. Thank you, sir.
Okay.
Thank you for attending.
Thank you. Okay, thank you.
Hello. Well, while we're waiting for Bauchi State government to speak to us, I want to give opportunity to our online participants to ask questions or make comments, provide insights on what potential.
And there are a lot of questions that have already been dropped. Can you pick them so that, Camilla has tried to respond to a couple of them. If there are those that have not been responded to, can we respond to them first, please?
Okay, sir. So we have some questions online in the chat. I think the first question is from Edache Abraham Abutu. He's asking that considering the US and potentially other foreign aid cuts on SRH and other health interventions in Nigeria, what strategies are being explored to leverage existing community structures, such as traditional leaders, community health workers, women's groups, to enhance demand creation and health education efforts? I'd like to direct this question to Dr. Boniface to respond.
Okay, thank you very much. So you're asking about strategies to leverage existing community structures. Definitely, like Dr. Aja mentioned earlier on, we are talking about our people, we are talking about our friends, our mothers, our sisters, our brothers, community members, and the rest. So I found out that there's a lot of resources in the communities because the people themselves are resources. You know, if they are harnessed, if they have positive health-seeking behavior, if they also know a lot about, eating healthy, exercising, as it were, they know when to seek for help and where to seek for help. At that level, the community leaders are very critical. I was just coming from Katsina State, where the traditional leaders, the religious leaders, you won't believe how knowledgeable these folks are, and their capacity to actually mobilize the community for accessing healthcare services like immunization for the 5 as well as pregnant women. But most times, some of these engagements do not really happen at that level, and that is a level where you do a lot with less resources, than in other places, as it were. Youth organizations, faith-based organizations, CW, Catholic Women Organization, Muslim Students Association, Form 1, there are so many, and each society, each community is unique because they have their own associations, including market women, including Okada riders, where they still are allowed to operate. These structures come handy to promote sexual and reproductive health awareness, because we are talking about increasing access to contraceptives. We are looking at increasing access to healthcare services for the pregnant women, for children under 5. We are looking at family planning. We are looking at and if you even look at it generally, these are places where these services are even more needed than even in urban centers, where they have various options in terms of accessing services. So I agree with you. We have not really harnessed that. The agency that promotes, what do you call them? The agency that actually engages with community in terms of promoting information and sharing information, National Orientation Agency. The National Orientation Agency definitely needs to do a lot more in the area of sexual and reproductive health, as well as other components of access to healthcare services. Awareness is critical at that level, and then these individuals can mobilize themselves. Several years ago, more than 20 years ago, when I worked in Benue State, we have women, just women who do small and micro businesses, coming together and supporting each other and encouraging each other to even access sexual and reproductive health services. I mean, these are women that have monies that they can put together and give one person a small loan. The person will do business and they rotate it around it. So these are innovations, creativity that is even happening at that level with a little support. I mean, a lot can be achieved at that level. Thank you very much.
Thank you, Dr. Boniface. We'll take the next question. This is from Elizabeth Ochanya. Sorry. Question from Elizabeth Ochanya Uda, and the person is, Elizabeth is asking, could this funding reduction open the door for influence from other donors with more conservative or restrictive views on SRH? I'd like to direct this question to Mr. Emmanuel Aja. It seems we don't have him.
No, I'm here. Sorry, I think I was talking without knowing I was still muted. Yeah, definitely. Elizabeth, good question. It is actually providing some opportunities. So there are other donors who are beginning to have conversations in terms of how they might be able to step up or step in and begin to bridge some of these gaps. So there are multiples of philanthropies. There are equally some other countries that want to continue to provide support aids. So, but what that means, following from my initial comment on this, was how do we bring all of them together? How do we ensure that they equally have a better understanding of how what is happening in the various countries where this impact has happened or occurred? and then be able to tap into what is happening from them. So, I mean, to answer your question straight, it's creating a lot of more other opportunities for others to step up. But you equally know that that stepping up might not just happen overnight. But there are multiple conversations that are ongoing now, and you're having, like I mentioned, some philanthropies, some individuals that just have money, and then some foundations that are saying, oh, we're actually trying to invest only 1 million, but I think the way it's going, we're actually going to be investing XYZ. Please always know that regardless of what happens in the US or what happens with Trump and his administration, there are individuals, even in the US, who are committed to ensuring that reproductive health rights are not completely trampled upon. So, beyond just the US, in other countries in the Europe, there are still others. But I think the larger picture of what we want to see is that how those the countries, the government of the various countries that have been impacted by this, they only begin to see how they pick up a couple of some of these issues and then begin to treat as well. Thank you.
Thank you very much, sir. Dr. Boniface, Jonah Akufa is asking, how can we advocate for increased internal funding for the programs, key population, and general population, putting into consideration some of these populations are criminalized? Would you like to respond to this? So, yes.
Sure. So it's a very good question. And like UNH said, if you leave anyone behind, you are unlikely to achieve global epidemic control. We'll be just deceiving ourselves because nobody is in a bubble somewhere. We are all connected in one way or the other. There are bridges between the general population and the key population. We are in one world. They don't live in a separate world somewhere. So it's important for the government to be very intentional about opening the spaces for people to access services if we want to achieve control of any epidemic. Because if you isolate anyone, it's a matter of time. You know, it will really backfire on the generality of any nation across the world. So for me, what we need to promote is integration of services, sexual reproductive health, HIV, malaria, tuberculosis, any infectious, non-infectious diseases. I was coming, from one of the states where, they are looking at bringing all of the clinics together as against having separate clinics for HIV, separate clinics for this service and the other, separate clinics for key populations and the rest. It would not really get us to where we want to be. So I think it's about opening our doors for every person born human, to access life-saving interventions, irrespective of their, identity, irrespective of their gender, socioeconomic or political status. Everyone should access life-saving interventions so that the world will be a better place for all of us, a safer place for all of us, and a healthier world for all of us. Thank you very much.
Thank you, Dr. Boniface. If Camilla is still online, I have a question that is related to one of the responses you had given earlier, but you focused more on the NGOs and touched a little bit on strengthening civil society organizations to harness the opportunities for domestic funding. I think this is related to it. Okay, she's not online. Okay, I'd like to direct this question to Emmanuel Aja. This question is from Mohammed Dudo, and he's asking that, given the significant role of USAID in advancing sexual and reproductive health in Nigeria, what practical steps can local NGOs and CSOs adopt to sustain community-level SRH intervention in the absence of funding? Perhaps
I think I have responded to something similar to this. There is really nothing the CSOs or INGOs can be doing when they don't have funding to do that. So, like I said, probably what we might need to do to sustain what is happening within the SRS space is so keen to what is happening within SWAP. It's equally to understand what will be happening within drawing some funding where possible through advocacy from the philanthropists that we have in the country. It's equally expanding our search to understand what is happening within the global community and understand where we might be able to draw in some funding and support from the different philanthropies that we have and those who key individuals who might be able to support. But largely too, it's equally being able to steward the funds that are available, the ones that are here currently now, but might not stay as long as we think, which was why it's become necessary to see what we build around government sustainability and government being able to support this. I mean, there will equally be no harm where it becomes possible for government to draw some technical support from the NGOs or NGOs or local ones that we have in country to be able to drive some of the developmental interventions that we have in the various states. So I think that's largely what will happen. But the truth is, where it becomes really very impossible for any funding to sustain the existence of all of these NGOs, be them local, be them international. Like my brother and friend Bartholomew mentioned, they have already closed shops in some locations and then asked some staff to go, and practically there's nothing we can do. So we need to find a way to weave this and build it around what happens at the state and begin to find out how the various states will be able to pick up what is left from those interventions. Why we equally work towards ensuring that we connect globally to see those who might support, and then as part of the learnings, begin to build high sustainability plan that can pick up what is left, because we don't know how long, even if we start to have those who are supporting now, how long they'll be able to do that.
Thank you very much. I think your response applies to Dodo's last question, where he asked about harnessing state and local government domestic resources to finance SRH programs. I think that's that has been answered also by your response. I hope, Dodo, you're satisfied with that. Next question. Let's see if there's any other.
You have my Ka Musa, whose hand has been up.
Hello, can I speak now?
Yes, please. Musa,
Okay.
you have the
All right. Good afternoon. My name is Mike Musa. I'm from Gombe State Drugs and Medical Consumable Agency. Thank you very much, Dr. Ann, for the wonderful work. And then congratulations to Mr. Emmanuel Aja and MSI for championing this cause at the right appointed time. I will want this cause to be built upon. I don't want us to have the same situation like we did in COVID-19. We had COVID-19, we all started shouting. It has exposed us as a country and the African region. And I think by now we should have gotten some gains from the case of COVID-19. And then we should be talking about consolidating on the gains from COVID-19. So MSI should champion this cause until we have addressed all the issues that have been mentioned by within this stakeholder engagement. Having said that, 3 items or 3 issues have been identified. One, which talks about the human resource for healthcare. The second one talks about the commodity itself, either the public health commodity, essential medicine commodity. And then the third one talks about the logistics, or how do we get these commodities to the end user, possibly having a visibility from the end user, that is logistic with end-to-end visibility. So for us to address issues on the human health resource, I think for partners, for developmental partners, there has to be, I know there should be a platform where partners meet, but there has to be a kind of an integration between partners. Because the truth is, for the states, they will always see partners as Father Christmas. If you come with a particular program, another IP is coming, everybody will be welcoming the program. Of course, it's coming to our state. But if there will be an integration, coordination from partners, whether you're a donor, whether you are an implementing partner, activity should be streamlined and integrated. I think we will have enough resources to be able to address the aspect of human resource for health. But I know the approaches has to be state-led, but the state is not frugal as you might think. So that being said, then on the concept of the commodity itself, I know immediately after COVID-19, we've been talking about medicine security, medicine security. We need, as a nation, as a country, to be involved on our medicine, how it is being produced, or at large, we should be involved in the production of our medicine. So the concept of medicine security might not really be an immediate action for now, but it should be something that has to be on the pipeline. How do we strengthen the pharma sector for productions and manufacturing of those commodities, either the public health commodities or the essential medicine commodities? But at the interim, like I said, when there is coordination, just like what the Commissioner of Health from Sokoto mentioned, we can approach the nation, at the federal. Look, this is what we have this is what we have as per procurement of such kind of commodities. At the larger end, this is what we intend to do, but at the interim, we need a budget line for this kind of commodities. Then on the process of logistics, how do we get these commodities to the end user? I think there are some states that have drug management agencies, which to some extent they are doing well. So if we can have an integration, I'm talking about LMD now, last mile distribution. If we can have an integration of public health commodities with essential medicine, then it will go a long way to be able to, cope these issues until we have a better framework to be able to address it. And also, I would want to still again commend MSI for this initiative. And I see FP, that's family planning activity. I see it having direct ripple effects on other activities. Because once you get your family planning activity correctly, you're going to directly have other activities rightly done, MNCH, TB, whatever, because FP, correct family planning, provide for correct and optimal utilization of every other commodities within the public health space. Thank you very much.
Thank you very much, sir, and thank you, everyone. We are about to round up this webinar. I want to really appreciate everyone, but before we close, I want to highlight that today we have been able to at least initiate the conversation around the impact of the USAID funding cuts, and we have understood from different perspectives how this has impacted the government, the implementing partners, and even the human resource that works in the development and humanitarian sector. We've been able to come up with various strategies on how these can be mitigated. Among these are understanding the funding landscape and the gap the funding cut has left us with, and exploring opportunity for domestic funding and using evidence to garner support for domestic funding. And we also highlighted the need for advocacy, timely evidence-based advocacy that will target the next budget cycle in the government sector to ensure that health budget is responsive to the problems that we currently face. That way we can have some immediate response and long-term impact, long-term response to address issues like this. Several other suggestions have been made on how to mitigate the situation, including local manufacturing of essential medicines and investing in distribution. And this comes with, ability to really quantify the commodities and be accountable so that we are actually holding ourselves to account for the commodities that we have. Human resource for health, and it was mentioned earlier that even organizations should begin to look at the mental health of those who work with them, because these things have far-reaching implications. I want to stop here now, and I must thank my panelists for the wonderful exposition, and thank all the participants for your input, for your active participation. It will be another time in Q2 to discuss some of these issues and many more.